All right, good morning, everyone. Welcome everyone to Grand Rounds this morning. This is an important annual event, and many thanks to Dr. Shu for his expertise and national advocacy in opioid education. As I think most of the residents may or may not know, but I know all the attendings do, your North Carolina medical license requires you to have at least 1 hour of opioid education every year. So again, this is a true service that Dr. Shu does for us to provide us with a formal CME granted opioid education. So for all those of you attendings online who have a full unrestricted medical license, make sure you recognize this for that purpose. For the residents, we actually recognize this through the ADS as one of your formal training and educations episodes in a designated area for ACGME guidelines. So we do much appreciate that. This will be the last, or not the last, the last Grand Rounds before our Thanksgiving break. So I wish everybody a healthy and happy Thanksgiving with your families next week. Anybody traveling, stay safe, and hopefully your flights don't get canceled. Then the following week, we will be back to a couple of weeks of our resident Grand Rounds, and then for our final visiting professor and Grand Rounds before our holiday break at the end of December, we're going to have Dr. Antonia Chen here. We're looking forward to that. She just was the program chair for the HACUS meeting. She is truly a rising star in that realm. So we're really excited to have her come down here in person to visit with us. So without further ado, in honor of our own Bayou Bengal, our CME color today will be purple. And I'll invite Dr. Shu up here to get going this morning.
All right, thanks, Josh. I actually changed the title to something simple so that for marketing purposes, so people realize that this pretty much meets our requirement. These are my disclosures, and they're relevant. We have a lot of federal funding to do the work that we do. I would like to pause for a second here and publicly congratulate Dr. Wally on her PhD. It's an honor to work around people that are so talented. I'd also like to congratulate Dr. Seymour on her mentorship of Dr. Wiley. It's really been incredible to watch over the years, that development and that mentorship relationship. It's really been a very special thing. So just like Dr. Pat discussed, there is a CME requirement, whether you're in North Carolina, South Carolina. Apparently in Georgia, it's just kind of a one-time deal, and then you're kind of done forever. So I looked that up the other day. The good news is 2021, here we are. So let's talk a little bit about what's going on with the opioid crisis. We're really kind of in the third wave of this opioid epidemic, or the modern opioid crisis. We're really now into the synthetic opioid phase. This started with prescription opioids. It transitioned to injection drug use with drugs like heroin, and now we're really into the synthetic opioid fentanyl type phase. And you'll see data like this. This is the most recent data. The CDC and other government agencies are very careful about how to attribute deaths best that they can. And so what you'll see is these data will lag about 2 years behind. So 2019, this is actually the most current finalized data that looks at deaths, and it is really driven by synthetic opioids. So people look at this stuff and they say, well, for physicians, it's over. For APPs, it's over. We don't have to worry about it. This isn't, the cat's out of the bag, this synthetic opioid thing. And it's not over. The reality is, and this is 2019 data, so this is the most current data where we can reliably attribute death. 38 people die every day from deaths involving prescription opioids. And so if people think that this is ancient history, unfortunately, it's not. And so the stuff that we discuss here is irrelevant. So let's talk about some good news. Maybe we have some good news. I showed this slide last year, in that OxyContin maker Purdue Pharma really essentially finally started to get a little bit of their due. They have been dissolved as a company, and started paying some fines. Unfortunately, due to some legal situations, they've actually been essentially absolved personally. This is a privately owned company by a family, and they've actually individually been absolved of any wrongdoing, despite evidence that they were directly involved in this work. I have no relationships with Hulu or Rosario Dawson, but apparently there is a new series that is quite good called Dope Sick. I haven't watched it. Has anyone watched this yet? It's good. Nick Johnson says super good, for those of you who haven't heard it in the audience. So I look forward to looking at this, although I have to take my yoga breath so you don't get inflamed by what has occurred through here. Unfortunately, even some of our most renowned consulting companies in this country, these are companies that consult and advise the government, foreign governments, the biggest businesses, the Fortune 50 companies in this country use this firm, McKinsey, and it turns out that they were also hired by opioid manufacturers to help with their work, and have paid and are paying fines now in the hundreds of millions of dollars range. But it is amazing to see the financial machine behind this opioid epidemic in this country. Again, the real challenge is what happens to this money. So we're throwing around $8 billion from Purdue Pharma, $570 million from McKinsey. What happens to this money? The reality is that the trickle-down effect for those families directly affected is pretty small. The real hope is that this money will not be squandered and will actually be used towards treatment and prevention strategies moving forward, since we're still in a situation where we not only have prescription drugs, but then it's overlaid by injection drug use and illicit fentanyl. Even some of the other companies that we have grown to trust in the medical industry have been involved in this as well. Interestingly, there was a recent ruling out of California that actually found in favor of the drug manufacturers and actually absolved them of responsibility in this. So this is the first lawsuit of this kind that actually found in favor. So this is on the bad news side, that there seems to be some moving back and forth in this zone. I'll show you a little bit about some of the North Carolina Opioid and Substance Use Action Plan. This has matured over the years. This is version 3 now. And this is what's going on within the state of North Carolina. Some of this work has been distribution of naloxone, as well as other harm reduction strategies. There are also incredible pushes towards treating people that do not have health insurance and really helping out those that are the most affected. There is also launched a residency training program for having the waiver to be able to prescribe buprenorphine, and some of the people here at Atrium have actually been part of the leadership of that transition. Some of the other things that are of interest to this group are there's an improved controlled substance reporting system. This is our prescription drug monitoring program in the state that has gotten better and doing a better job at enabling people to query that in some of the health records throughout the state, and we're hoping it'll be us soon. You can actually directly assess those data from within the EHR. Other things that are a little bit of an update and some excitement around it is that there is some decrease in the number of individuals that are dispensed opioids. And so you'll see the prescription rates have been going down, although there is still a fair number of deaths, as we discussed. And there has been an increased focus on the uninsured and the underserved to receive opioid use disorder treatment. Unfortunately, due to COVID and due to the various challenges that we've had in the recent year and a half, there's actually been a little bit of a resurgence in overdoses. There is actually this polysubstance increase as well. So now we're seeing overdoses that involve not only opioids and synthetic opioids, but also involve various stimulants that really had a lesser of an impact in the past. So again, now most of the overdose deaths are related to polysubstance use rather than a single opioid. And so this really needs to morph into a greater conversation, not just around opioids, but into some of these other co-prescribing and other substance use disorders, to include alcohol and other types of substances. So again, one of the challenges in the goals moving forward in the prevention is to reduce this inappropriate prescribing and really expand appropriate pain management that uses some of the strategies that we'll discuss here a little bit today. So one of the things that's news for 2021 is we are now required, it's a mandatory review of the prescription drug monitoring program. I always stumble on that word despite a tremendous amount of time doing this research. And so ours is a controlled substance reporting system, and this is mandatory. This started in July. And so anytime you have a new prescription with a patient, you're supposed to go into the CSRS and then check their 1-year prescriptions. And then anytime you renew within like a 3-month, if you continue a prescription for more than 3 months, you're supposed to check it again. And that started in July of this year. It is easier to use now, and so people are supposed to be registered for that. If you're not registered, you can go to this link. This is the login link, and then it'll also allow you to register as a new user. It used to be a pretty painful process to do. When I did it, I understand it's a much easier. Has anyone registered recently? I understand it's a much more streamlined process now. It used to be this laborious process before that involved paper and mailing stuff back and forth. One of the things that I would like to highlight that's already available within the EHR currently, if you go to the workflow view within your EHR, you actually have the ability to click on one of these hyperlinks. And so this is for North Carolina and South Carolina. Moving forward, and we'll talk a little bit about the Epic transition, but you can go into this and you click on that and it automatically launches you into that. It doesn't connect to the patient's chart directly like we hope to in the future, but it allows you a link to go in and do that. The other thing that it allows you to do is click that you've reviewed those data. And not only does it record it for us, but it will suppress any further alerts. So all of the different prescription alerts that you get, if you click that button that you've reviewed it, it suppresses those alerts. And whether or not this meets the currently, there is still a note there's still a requirement in the state law that you put a note that you reviewed it. So moving forward, as we transition to Epic, what we want that to do is create auto text for you. So when you click that button, it creates auto text. So now you don't have to generate a separate note with it. And I think most of you know that a lot of this work with order sets and the acute pain stuff that we've transitioned into the acute care setting. We started the Primum work as all outpatient prescriptions, but now we've really transitioned into order sets. And again, this is really a balance of safety and comfort. This is not about just restricting opioids. This is really about making sure that patients have the appropriate type of relief and pain management that they need, but also in a more modern and safe way. And that really involves true multimodal pain management. It's not about a pharmaceutical strategy only. So you hear people talk about opioid safety and you hear people talk about pain management. It is a cocktail, and more than a cocktail, there are physical and cognitive strategies. And we'll talk a little bit about some of these, and I'll highlight one that I think is interesting and easy to do. Because really philosophically, the goal is to have this scalable, meaning that a lot of people can be treated with these different strategies, and to have it applicable, which means no matter where you are, if you're Center City, Charlotte, or you're more rural North Carolina, South Carolina, Georgia, that these things apply to you and you have access to these resources. So this is what it looks like currently in the EHR. And I think most of the people in this room, I'm preaching to the audience a little bit, y'all are using this. I know because I get a report, I get a spreadsheet every Monday for who's using it and who's not. And this is Adult Opioid-Sparing Pain Management is the title for this. So you can search that title within the EHR if you've not used this record before. And one of the things that I'll highlight, I'll go into a little bit more detail when I show you the new Epic build, is there's a lot of items that are pre-checked. And the pre-checked items tend to be the physical and cognitive strategies for pain management, because they're things that we forget, right? So when you're going through your busy day, you're not going to remember to put the ice on the patient, order the music induced analgesia. You're not going to remember that stuff, but the nurse will remind you that, hey, you didn't put the person on a narcotic, but they don't remind you about anything else. And so we pre-check that stuff for you. It's not pre-checked and not modifiable. It's modifiable. So if you say, you know what, I do not want ice on my patient, I protest ice, you can uncheck it. So you have that option if you think that your patient listening to music will somehow compromise their outcome. So the reason why I talk about music, I thought it'd be a little bit interesting to talk a little bit about music-induced analgesia. And I say music-induced analgesia because when you say music therapy, people get in their mind that there's like some harpist sitting by the bedside. And, I mean, that would be fantastic, but that's not scalable. That works for one patient at one time. And it's not applicable because you're not going to really go out into our rural communities and have someone from the Charlotte Symphony out there at the person's bedside. The music therapy people are incredibly talented, and it's more than just music. They do a lot more than just music, but I wanted to focus on music-induced analgesia, which is essentially listening to music, streamed music, or however you bring your music in. And it turns out there's really tremendous data. So this is and I'm just going to show you some meta-analyses and reviews because getting down, and there are a lot of papers on this. But this one really looked at chronic pain. You think, well, how is music going to help with chronic pain? We've talked about this before, is that that pain and anxiety are very, very closely related. And if you really talk to your patients, you really listen to them, they'll tell you that part of the reason why their pain spikes is they become nervous about their pain or anxious about their pain, or they feel like, I'm not going to be able to get through this. And they get this level of desperation that occurs. And then the pain level increases. This has been studied for decades, so we know that. So if you can decrease the anxiety, it's just not because it's, quote, in their head. It is directly related to their pain perception. And so the focus on anxiety reduction is important. The challenge with anxiety reduction is a lot of the strategies for it are not scalable, but music-induced analgesia is one. And even in people with chronic pain, music was found to have a tremendous effect on not only self-reported pain, but these depressive symptoms. In this chronic pain population, the patient choosing the music seems to have a better effect. So the type of music, the cadence, the tone, it doesn't really matter as much, or at least we can't tell from the literature. But it's up to the patient to choose, and you'll see a wide variety of what patients choose. When we were full in-person clinic, we used to have the MA open YouTube in the clinic rooms and play music based on the patient's choice. And it was always interesting to kind of go into the room in the clinic and listen to what the patients were listening to. So you say, well, that might work for some medical patients or some, chronic pain patients. It's not going to work for surgery pain. This is surgery pain. We're going to surgerize some people and cut the pain out. Well, it turns out that it actually does work for postoperative pain. And interestingly, a lot of these, you've heard me talk about this with aromatherapy before, where the strongest effect was in the post-surgical patients. It's really interesting to see, because what sometimes we underappreciate as clinicians is this peri-surgical period is incredibly anxiety producing for patients. So it turns out that pain reduction occurs with music-induced analgesia, as well as reductions in anxiety, and in this post-op patient population, decreased opioid use in this review. Also showed increase in patient satisfaction. Length of stay did not differ with the use of music-induced analgesia in this patient population, though. This is a different review that really looks at peri-op. So this looks, pre-op. Even what's really interesting right now, they're starting to do studies on intraoperative music. And it could be the death metal that we're listening to while we're doing the surgery. But what they've done is they've actually are starting to put, in some centers are putting headphones on the patient and having music choices for them. And it's super interesting. I've seen just a couple of those studies that are early on that have actually shown decreased opioid use, even intraoperative. But this perioperative work is super interesting because it starts out in the preoperative period, because it's the whole experience for the patient. And again, this is very easy to do, very scalable, and we'll give you some ideas for how to execute on that as well. And so if you look here, that zero line, So anything to the right favors the control, anything to the left favors music. And so anxiety scores, pain scores, a lot of these different things they favor the use of music. And so you can imagine this is a cheap intervention with essentially zero side effects that we can tell. So what about orthopedics? You say, you know what, you just showed us about surgery, and I mean, if you have like some little lump or bump taken off, that might not be it. So what about orthopedics? It turns out that it also does work in orthopedics for reducing the patient's self-reported pain and anxiety. In this review of orthopedic patients, it did not show that it decreased opioids, but it did show that it decreased pain and anxiety in that patient population. What about for a younger patient population, right? Well, it turns out there's really good information on anxiety reduction and its relationship to pain in the pediatric population. As far as post-surgical pain, it did demonstrate a positive effect for pain, anxiety, and distress as well in that group. So how do we do this? At least when the patient is in their room, there's a pretty easy way to do this. So we have the GetWellNetwork is on their televisions, and so they can go in, and this is one of the pre-checked orders in the pain order set, and they can go in. You can see there's Pandora's on there, and so they don't even have to use their own stream. They can go in there and listen to Pandora, and they can pick whatever they want to do that. If patients would prefer to listen to their own devices, they can also listen to their own devices. And a lot of times it's really just bringing that up to the patients and the families, and they don't really realize that music has a really positive effect on that. And then it's funny because I actually have a patient that I'm doing a 2-level deformity correction on, and he battled with opiate use disorder during some of his previous surgeries. And I brought up this concept of music-induced analgesia, and then he endorses it right away. He's like, oh yeah, I'm way more calm when I listen to music. And so people sort of know this, but you forget because we medicinize everything, right? So if it's not a pill or a prescription, it's not kept in the safe or the medicine cabinet, then we don't think that it actually can be a good therapeutic for what we're dealing with right now. So then within our order sets, the current order sets, we also have a variety of opioid options. And as we've talked about before, they're not ranges. They're not 1 to 2 every 4 to 6. They're very specific for a variety of reasons. Number one, we don't want to overdose people when we have wide-ranging prescriptions like this. We don't want to allow patients or nurses a triple a dose in a wide-ranging prescription. We want to be very specific about it and prescribe with precision. The other thing that prescribing with precision does is, for those of us who like to use acetaminophen as an analgesic, which has very, very good data as an analgesic, you have to watch out for your toxicity. You're allowed about 4 grams a day. So what happens is people then use an uncombined opioid so that they can use an acetaminophen because they're worried about overdosing on the acetaminophen. If you prescribe with precision, you know how much opioid you can give. You can give a combined analgesic, which probably has a better effect, and it doesn't get us down that same pathway that we got through with OxyContin. Because remember, that started out as an inpatient medication, and it's like, oh, well, it worked as inpatient, send the patient home with it. So now some of these pathways that are considered modernized pathways with scheduled acetaminophen, we're sending patients home with a pile of non-combinated opioid, and that's what actually has tremendous street value and reuse and has very, very high overdose potential. So again, what I'd like to transition to talking about is our EPIC transition. And so this is an area where, I do have to say thank you to Dr. Wally and Dr. Kempton, who've really led this work. I've honestly kind of helped out in the background on this. They've led this transition work along with our Winston-Salem colleagues to transition this pain work into our new electronic health record that starts for a variety of the sites, is rolling out here now. I think in the Center City we roll out in April is a current timeline. So the title of this order set will be Opioid-Sparing Pain Management Orders. That will be in EPIC, and it's going to look like this on the top. It's going to have your non-pharm strategies up front, analgesics that are non-opioid, moderate pain, severe pain, and then stuff around rescue medications after that. So this is what the non-pharm, we'll go a little bit more into detail. This is the non-pharm pain management. Again, what you'll see is there are pre-checked things on here, right? And so pre-checked things are things like a TENS unit, things like ice, allowing a PET and some other things around nursing communication for the music-induced analgesia. So these are pre-checked. So if you say, you know what, the last thing I want my patient doing is seeing that fluffy dog that they bring around to make them happy, you can uncheck it. We have that right. But we wanted to pre-check a lot of these things just to make life easy for everyone and really give that rounded experience for patients with true multimodal pain management. As far as the non-opioid analgesics, it's the ones that you know and are comfortable with, acetaminophen, NSAIDs, et cetera. Those are all pre-checked on there. And you have the ability not only to uncheck them, but then to go in and modify. You can see there's a variety of different options that you have to modify those. And just side note while we're talking about this, this build is still underway. And so if there are input or anything that you think should be added or subtracted from this, please send that information to either me or Dr. Wally or Dr. Kempton. Probably Dr. Wally. If you really want it to get done, probably Dr. Wally. Let's be honest, let's confess. All right. And then again, as you start ramping up into moderate and start going into severe pain, then you start seeing the introduction of some of the opioid analgesics as well. And so this is what severe pain is going to look like as well. We also built in safety mechanisms as well. And part of this is to actually have regular nursing assessments of patients before they dose them. That's been one of the challenges, again, is a patient, and we've all been there where you have a nearly unarousable patient, you wake them up and what do they say? My pain is 10 out of 10. It's like your respirations are slow. You can't keep your eyes open. And so there are scales like the SIR scale that we've introduced before. And so the nurses are required to do a sedation assessment for secondary side effects or for side effects of the medication before dosing them. So those will be recorded. And then we have a mechanism in place for the unarousable patient and whether or not they need a rescue medication like this. So the other thing I wanted to highlight again, and this next part will be fairly redundant from some of the other things, but I want to make sure that you have it. And then Susan has this slide deck as well, and it's probably worth sending around because people the next little section, they might even want to print off and use in their clinic. So we had the pleasure of leading the clinical practice guidelines here for acute musculoskeletal pain that was sponsored by the Orthopedic Trauma Association. And one of the things that we did is the problem with a lot of these guidelines and reviews and things is they say can't find for, with, and can't this and that. It's not something you can implement into practice. And so when we went into this, we said we want to give people tools. We want to give people something that they can take to their PA or they can take to the nurse and say, do this. And that's what this is. These are the opioid tapers. Actually, Hassan Mir and Dr. Wally are the ones who really worked all this stuff out. So it's a 4-week taper. This is for major musculoskeletal surgery. You'll see we have it tiered. And I mean, this is what I do. My clinic has this, and it's basically do this. And the residents and the fellows know to do this. And it's fairly simple. It's standardized, but it is tiered as well. So it's not one size fits all. It is tiered so that people can taper. And we call it a taper. And again, I've talked about this before. The word refill, I start to move that out of your vocabulary and use the word taper. And patients will understand that a little bit better because they'll call and they'll say, hey, I want a refill. And I say, no, we don't give refills. We do a taper. And so they understand that every time they call back, they're only going to get 7 days because that's what the North Carolina law says. And it's going to be a taper, which means less than the week before. So for minor musculoskeletal surgery, the taper starts out with a little bit lower dose of an opioid. It still has all your other pharmaceutical strategies as well. And then for a non-operative patient, the non-operative patients and I think should mostly be treated without opioids. There is a light opioid like tramadol that we do allow in the taper. It's what's one of the interesting things is even some pharmacists will tell you that tramadol is not an opioid, it's a synthetic opioid. And so if they tell you that, correct them and say, yes, it is a synthetic opioid. There are side effects and overdose deaths associated with tramadol, especially worldwide. It's a problem worldwide. It's less so in America because we got fentanyl. So that's a reason why it's less of an issue in the United States as compared to other areas. One of the interesting things, and I'll highlight a couple of different studies, and I'll wrap up so we can have some open discussion about things, because we have some real experts on this in the room as well. I'm just honored to be able to kind of pull some of this stuff together and open the dialogue. There was an interesting study that was done by some colleagues in orthopedics in San Diego, and they basically did a multimodal strategy for pain management in the era after the opioid, after the guidelines that we did for the OTA. And it's actually very similar to the OTA CPG. And the references in their paper are OTA. I actually need to reach out to one of the authors who I know and talk to them about this paper. But basically what they did is by implementing that CPG, they not only decreased their opioid consumption by greater than 50%, but they increase their patient satisfaction scores. And so one of the things that we'll talk about maybe in future opioid talks, we'll talk a little bit about opioid-induced hyperalgesia, which I think is one of the effects that you're seeing in the core study as well, where the people that were on the non-opioids actually reported less pain. I think that we're underappreciating opioid-induced hyperalgesia, which is an increased sensitivity to pain that comes from having opioid in our system. And so it's super interesting to see these studies that show better pain satisfaction with less opioid. And you say, well, does this work in a pediatric population? The interesting thing about this paper is they tiered their protocols in this pediatric population, the same way we kind of tiered the OTA CPGs. And, you know, we didn't have anything to do with this. This is one institution's guidelines that they created internal with these tiered things, basically saying anything from like, you know, a big spine surgery to, you know, something smaller. And they tiered it and actually were able to show, they looked to see compliance, and most of their practice was within compliance, and they were able to decrease the quantity of opioids used by having this sort of tiered protocol that was a locally based protocol. One of the challenges we have when we talk about, you know, decreasing opioid use, again, is the satisfaction scores. Are we going to get slammed on our patient reported satisfaction scores? And actually doesn't seem to be that way based on other studies in the peer-reviewed literature. And so we looked at that here. Dr. Karenacher had the idea to look at it here and look at our comments that our patients make around opioids. And Eric Sechrist took this on with a bunch of the other residents that are in the room. And looking through over 7,000 comments, there really were a very, very small percentage, less than 1%, that had anything to do with opioids. And this is the Prescaney comments that the patient did. And so it really didn't seem to be associated with what the patient satisfaction comments were either. So not just their overall scores, but what comments that they made. And then what I'll do is I'll wrap up by, you know, a lot of this quality work is very heavily integrated with research. And so to round up the update for the year, just to kind of let you know where we are on some publications, not only from 2020, but 2021. And so 2020 was a good year for publication around this work, with, you know, the great work that's been done a lot by the residents in the room, and some recent graduates as well. And you can see, I mean, the work has really been around cannabis. It's been around patient satisfaction. It's been around synergistic impacts of opioids, as well as opioids in the arthritic population. 2021 is year to date, several studies as well in different populations. Again, residents have really helped lead a lot of this stuff with dental work, the shoulder work, as well as core publishing on their RCT of opioid-free versus traditional. So thank you again for your attention. I think we have plenty enough time for questions before we have to wrap up today.
Thanks, Joe. Again, anybody in the room is welcome to ask questions. We are recording today, so we'll use these microphones and pass them around. Joe, let me start. First question was online from Dr. Hamid and said, thanks, Joe. What are your thoughts on gabapentin? Seems safe, but efficacy looks so-so. Still include in multimodal pain?
Yeah, it's really interesting. So there's more and more work being done on the gabapentinoids and studying that. Early studies were great. It looked like it was going to be, a great solution. I think what it's doing now, it's probably not decreasing your opioid dose, so the amount of opioid that someone takes in a day, but maybe shortening their duration. And so the studies that look at duration of opioid use are important, because if you just look at the MMEs that people take per day, it has not been shown to decrease that. But in the weeks after surgery, if we can shorten that, because what we do know is that the longer you're on an opioid, the greater risk you are for long-term use. And so if that helps us to shorten that, then it can be good. We do have to be careful about it in certain patient populations because it is sedating and in and of itself can cause some respiratory depression. There's some chest data that shows that maybe it's not working as well in that patient population. So some of our older patients, we need to be a little bit careful. The one thing I'd say is if we say, hey, I don't want to give a gabapentin because I'm worried about sedation, then we have to be careful that we're not substituting that with more opioid that we know will have those side effects. And so the way I'm thinking about gabapentin now is the same way we need to think about opioids, is start low and go slow. Because you can start with a relatively low dose, like 100 milligrams, maybe just in the evening, and then slowly go up if needed. But I think that's where we are right now on it. But there are studies now on both sides.
Joe, thank you. Just from a faculty standpoint, I appreciate you doing this annually. It obviously helps us significantly. Two questions. One, do you know from an EPIC standpoint, is there anything being developed in the pediatric world that's equivalent to your opioid-sparing? Obviously, it's weight-based for children, especially for kind of the Toradol, the hydrocodone, everything. Do you know if anything's being done right now? If not, that's probably something we should get on as a children's hospital too. But nobody's talked to us that I'm aware of.
I'm actually not sure, but I think that's a great point, and it's something that we could do. We need partnership from people like you, and I think it'd be
a great QI project for any residents that might be interested in helping. All right, perfect.
Because we have the backbone already. It's just getting the right people on board. And as you know, it takes some time to get the other non-orthopedists to be part of that family to develop it. And so we're happy to do that. But it's a little bit of a process, but it's definitely worth doing.
Yeah, I think it would be great to do. So I think that's something that we can look into. And then the PDMP, I don't do a lot of prescribing on the atrium side because they do it for me. On the EPIC side and outpatient surgeries, I do all the prescribing there. The one thing that's been nice, and hopefully EPIC, and you had mentioned it a little bit, instead of just clicking and then having to log in to North Carolina, it is a one click that opens up the patients. Is that going to be the same for EPIC
we think so.
Atrium?
We think so.
It really, and it doesn't allow you to kind of move past that next step. So from a quality standpoint, if you have that one click that you have to do, and it's not multiple clicks, sign in, I think it'll be much more utilized in the right way that we all need it to be done.
Yeah, that has been a multi-year process to get to that point, and I don't take credit for it at all. We were getting defeated on being able to make that happen in Canopy.
Yeah, Joe, thank you again for doing this, and just a couple of comments. I would say that probably total knee and total hip replacement are not in your small bone category. But for virtually all of the total hips and total knees that we do, we send them out, or that I do anyway, we send them out on Tylenol and Tramadol. We give them, for the total knees, we give them a total of 20 tablets of oxycodone and tell them not to get the prescription filled. And there are a couple of things that help with that. That article from Lancet a number of years ago looking at opioid-induced hyperalgesia, very instructive for me in 2 points. One, the less opioid that they get exposed to, the less pain they're going to have. And it's very, very clear from sort of my empiric experience with that. If indeed you instruct them to take their Tylenol first, the onset of activity for Tylenol takes 45 minutes to an hour to actually work. So having them take that and ice and do some of the other strategies before they take an opioid, their effectiveness of the tramadol is approximately 40% greater than it would be if they took the tramadol alone. So taking the Tylenol, giving it an hour, splitting those medications and being very instructive in terms of how they take it, they do extremely well with much less narcotic.
It's a great point. And for people who can take NSAIDs, there are low back pain trials that are blinded studies that show that the combination, so if you have an acute spike of pain, you can take your NSAID and your acetaminophen together, and they work as well as the opioid in blinded trials. It's really interesting. Yeah.
Thanks, Dr. Shu. I just had a question on Robaxin, just what your thoughts were. We used it a lot on gen surge trauma, and oftentimes get patients coming back to ortho trauma clinic asking for refills, but obviously it's not a part of the opioid sparing. Just didn't know what your thoughts were and if there was a reason it was kind of left out.
Yeah, the problem that we have around some of the muscle relaxers and even some of the antihistamines with these sedating / muscle relaxing side effects is as it combines and has respiratory depression. The data on it has not been that great, and so instead of adding that in, we've done gabapentin as well. One of the other nice things about gabapentin is there's an anxiolytic effect to gabapentin, so that's one of the reasons why we went with that instead. The challenge that we have with the whole muscle relaxer category is outside of benzodiazepines, we don't really have a good concept for how they actually work and what the true effect is. The benzodiazepines actually we understand pretty well. Unfortunately, when co-prescribed with an opiate, those get to be pretty dangerous.
Joe, fantastic talk. One question for you. It's a specific question. If you go back to Excedrin and some of the old multimodal analgesics, they always use caffeine as an analgesic adjuvant. What's the latest on that? Does caffeine help with this? Should we be prescribing coffee along with the opioids, or is that an old wives' tale?
For me, yes. Actually, I don't know. I don't know any modern data on it, but I know that there were some studies from years ago on even intravenous caffeine in the perioperative period and increasing patient satisfaction. They didn't look as much around pain. It'd be something worth looking at. One of the challenges with caffeine, though, it's actually a relatively toxic substance in small doses, and so you have to be a little bit careful with it. So when delivered orally, and 40 milligrams of caffeine in a cup of coffee is relatively benign, but I think it's definitely worth a lit review because I've not seen that in any of my recent lit reviews. But it's interesting. That's a really great concept, and I have no financial relationship with Excedrin, but I'm a customer.
Joe, maybe one final question on the anesthesia side. Listening to Dr. Mason's comment referencing that Lancet article, I know in Dr. Hammond's study, they really focused on intraoperative narcotics as well. What is happening systematically on the anesthesia side at our institution? Has there been any direct work there? I happen to just remember yesterday at the end of one of my cases, they were actually very excited that they'd given him no narcotics during surgery. So is there anything on a formal way happening in that space?
Yes and no. I mean, I've partnered pretty closely with anesthesia for several years on having opioid-sparing pathways. And really it was driven by patients of mine. Actually, a couple of patients in particular, one of them is a wounded warrior who comes here who really struggled for years with opiate use disorder. He actually says that getting off opioids was harder than getting his legs blown off. His statement, not mine. And so we made sure that we had opioid sparing pathways for people like that. And so they are there and they're available. And as a matter of fact, Ben Avercamp is looking at a series of over 100 patients that we've done at one-day surgery that had osteotomies and non-unions done in an opioid sparing way. And so I think that just like Dr. Mason was saying, that intraoperative thing, if they're hit heavy with opioids intraop, then it has that opioid-induced hyperalgesia on the back end. The other thing is we don't think about postoperative nausea and vomiting. I mean, these people are miserable when they come out of a high opioid anesthetic. If you're doing someone under regional anesthesia with a low to no opioid anesthetic, they wake up and they're ready to go home. I mean, you have meaningful conversations with them in the PACU. It's actually super interesting to do it that way. And so there are, as a matter of fact, a call out, and it's a due out that I found out about earlier this week that I need to get with you on, is we have an opportunity to join anesthesia grand rounds in February. They're bringing a special guest speaker on regional anesthesia. And I think that maybe help alleviate some of the concerns that people have around regional anesthesia, because that's really part of it. So it's regional anesthesia, it's using medications like Precedex instead of opioids. And you really can have a tremendous surgery, analgesic effect. Some people are concerned about, there's not a paralysis if you're doing people that are more awake during the surgery. And even in fracture reduction surgery and non-union, malunion work, I've not found the need for all those other layers.
Great. Well, thanks again. Appreciate your insight and knowledge in this area. And we do have a separate link, I think, and maybe in person as well for resident conference to follow this. So thank you.